Lovely to hear the conversations over lunch and actually to see all the comment cards getting filled in and put in the box as well. Let's keep the conversation going as we move into the afternoon. We're going to hear economic evaluation from Martin Knapp. We'll hear a little bit more about some practical examples from Paul Frijters, and then some practical tools and resources from Ingrid Oberscherer as well from our team. And then we'll have a coffee break, and then in the afternoon be more detailed sessions. And we'll hear from Jan Emmanuel on the objective benefits of wellbeing, and then Lord Gus O'Donnell will close our day. So welcome back to the afternoon. I hope you no longer think wellbeing is fluffy, and I'll hand you over to Martin.
Okay, thank you very much. It's always a good idea to have economics straight after lunch, particularly cost measurement and other such exciting things. So this is a test of your real commitment to this course as to whether you stay awake. And my surname is not chosen randomly for being the after-dinner speaker, so after-lunch speaker. So when we think about economic evaluation, what do we think about? 5 things I put on here. Clearly, we're firstly interested, or our starting point could often be the outcome. So what is achieved in terms of benefits, gains, effectiveness of a particular program. And we've heard a lot about wellbeing as a measure of outcome. I'll come back to that later on. So clearly we're interested in that. Secondly, we're interested in actually how does that change. I was already falling into that in the first relation to the first building block. How has that level of wellbeing, or whatever it may be, changed before and after the policy change or the intervention, or over time in some sense? Thirdly then, once we get into that, we need to think about, okay, so what would have happened without that policy change, without that experience? So we're into the issue of comparison, comparative to what? Then the economic evaluation would say, well, let's bring in the cost side as well. How much do we have to spend, or what resources do we have to allocate to achieve those outcomes that we've just seen occurring over time? And then we get to the 5th one, which is the trade-offs, because quite often an intervention, a service, a policy may well may look good in one respect. It improves well-being, for example, but it may not look quite so attractive in another respect. For example, it costs more money. So we have this issue about how do we trade off those outcome well-being gains with the higher costs that may be needed to generate those gains. So those are the building blocks that we need for any economic evaluation. And what I'm going to do is go through and just talk through the key objectives of economic evaluation, something briefly about cost measurement and outcome measurement, and then even briefer on study design, and then discuss the issue of making trade-offs. I'm very conscious of time. I'm not going to run over my time, 1:30, to give time for Paul's examples. And then after the examples, I'm going to come back and just go through 2 examples in a sort of broader context, which use very different designs. One of the studies I show you today would cost about £1 million probably. The other one costs last year £95,000. They're both very useful. So 2 different ways to get at economic evaluation. So why economic evaluation? My students, particularly the undergraduates who are not altogether thrilled by this topic sometimes, to get them engaged, I just remind them about my name. I've already used it in relation to your short sleep. I'm going to Stockholm later this week, where I'll be introduced as Professor Knapp. And Knapp in Swedish and many Germanic languages means scarce. So I was born to be an economist, but scarcity is where we start. Okay, so scarcity is the issue. We don't have enough resources to meet all needs. We therefore, decision makers therefore, have to make often quite difficult choices, weighing up the pros and cons of the different alternative uses of those resources. And consequently then, when they're thinking about whether to invest in a new service or interventional policy, they've got a whole range of questions. And the ones I put on there, is this service or intervention effective? The outcomes issue. Is it affordable? We can actually find the resources today to deliver it. Does it save money? Doesn't have to, but it'd be quite attractive if it did. And is it cost effective? And we need to define what cost effective means in a moment. Now, there are other criteria, lots of other criteria, and the discussion this morning around distributional issues, inequalities, clearly highlights many of those other criteria. I'm focusing here, and Paul and I are focusing here on the sort of efficiency criterion, but these other ones are at least as important when making decisions. You all know that. Now, where is economic evaluation evidence used? I've just listed some things there. I'm not going to go through and talk through those different uses. My point is that there are many different audiences for economic evaluation evidence, many different people who are commissioning economic evaluations to help them to make better decisions. And what I put at the bottom there, different needs and uses could mean that different types of economic evaluation are required. So it may well be that an evaluation which is conducted for health service commissioning of new treatments needs different information, or in some ways is not quite going to satisfy the needs of people who need evidence for some other purpose. So just need to bear that in mind. So there isn't one type of economic evaluation which necessarily can answer every question or meet every need, although there are some principles that we're going to get through today which are, we think, common across those different needs. Okay, so I'm going to go through cost measurement because it is ever so exciting quite quickly, and outcome measurement quite quickly too. On the cost measurement side, there are kind of three elements that we need to think about. Some of you will be very, very familiar with economic evaluation. Some of you will not be so familiar, maybe thinking about doing some of these things. One is we need to decide actually how broad do we want to measure our costs, and I'm going to show you a couple of examples of that. Secondly, once we've decided what we're trying to measure, we need to have some indication, we need to get some measure of the level of activity or service utilisation I will use. I do a lot of my own research in the health and social care area, so I tend to think through that particular lens, or look at that particular lens at these questions. And then third stage is, so what is the cost, the average or the unit cost we need to attach to those different patterns of utilisation. So on the costs, the breadth issue, what I put on here first of all is a set of factors which might influence the needs that individuals may have. It may influence the strengths they bring, the assets, the psychological and resilience and other assets they have, but their needs are going to, I'll show you in a moment, lead to some services. Now I'm going to say almost nothing more about those pink boxes here, but I do want to emphasise that they influence not just the needs of individuals and the assets, but they influence, in many ways quite importantly, the costs of meeting those needs. And they influence the outcomes achieved by people with seemingly the same level of need. So these are the factors we need to adjust for when we're doing our evaluations. And when I get back to the examples later on, maybe they'll come in a little bit there. What I'm more interested in is how those needs translate into utilisation of different services or a range of other, quotes unquote, economic impacts that we might see. So I've just listed there healthcare, social care, housing, a whole range of other sectors, and individuals with particularly complex and multidimensional needs may use many of those, may visit many of those sectors, have impacts on many of those different systems with potentially many costs. And the point about that is, if I add that little set of boxes on the right-hand side, that those services or those impacts are felt in different budgets, different parts of government, different parts of society. And so the more complex an individual's needs may be, the more complex the cost measurement needs to be. But our systems of data collection and so on actually don't support that complexity very easily, very well. So an empirical evaluation would normally need to go beyond just one agency, one budget system, to look at a whole range of others because of the needs and the patterns of utilisation of services of individuals. So that's the what costs question. Now let me just illustrate that with two studies, and they actually play out quite nicely to this morning's talks from Richard and Andrew, with the focus on child mental health issues and the importance of child mental health for well-being experienced across the adulthood life course. Now, this is just a simple pie chart describing the costs of young children with persistent antisocial behaviour. Some of them would reach a threshold for diagnosis within the standard systems of mental health. And what you can see there is that these children have a range of economic impacts. The bits of pie up in the top right are the service systems, healthcare, social care, education, some charitable sector services. Big impacts on family, either in terms of damage to the home or, more importantly, one or more parent having to work fewer hours or fewer career opportunities than they would like. And then if we're thinking about the impact on the system, might be some benefit consequences coming from the DWP part of government. So we've got already a very simple need which is spilling over into having many possible economic impacts. Now, I take that same group of children, or a similar group of children, and just going to show you something that happens over time. This is a study conducted in 1970 by Michael Rutter, who's a very eminent psychiatrist and psychologist, who was looking at the prevalence of child mental health problems, very little evidence around at that time. And what he did was look at a whole bunch of 10-year-olds in one London borough, and then look to see what their needs were in relation to mental health. And then later on, he and colleagues followed these people up when they're in their late 20s. And we then took the data and looked at those groups. I'm going to focus on the groups in the red font. Children, one group who had no problems, no behavioural problems at all, none at school, no clinical diagnosis. A second group who were antisocial at school, they were a pain in the neck to teachers, might be the technical term. And then a third group that if they had been assessed properly, would reach a threshold for a mental health problem called conduct disorder, which is very disruptive consequence. So the question was, what happens over the next 18 years after these assessments? And what you can see here is that the three columns from the left, it's the group with no behavioural problems, the one in the middle, the group that are a nuisance at school but don't reach the threshold for diagnosis, and the group on the right who would, if assessed, be diagnosed with conduct disorder. And what you see now is, again, a mix of colours, a range of impacts they have, and the biggest impact of conduct disorder at age 10, which is actually relatively late for interventions, but at age 10, the biggest impact is in the criminal justice system. So to do something about this, we would need to, if we're worried about the balance of costs and benefits over time, how do we then persuade bits of the criminal justice system to put money into the health system to provide the sort of treatment, psychological therapy that would work for those young people? And there is one police commissioner in England who has invested some of his budget in family programs, family treatment programs for children with conduct disorder, because he reckons they are his customers in 15 or 20 years' time. So we need that sort of breadth of perspective, both for evaluation and then for decision making on the basis of it. Okay, that's showing you twice because I like it so much. Now, in terms of the costs that we would include in the evaluation, there are a number of things that we would want to include, depending on where the study is coming from. So if we were doing a study in the health system, for example, we might look at those sorts of services. We then look wider at the broader public sector costs, and then depending on the nature of the evaluation and the approach that's taken, and the approach that I might take might be different from some other people, would be we'd have some economic impacts, some cost impacts elsewhere. So quite a few health and social care services are paid for by the individuals who use them or their families. Now, there'll also be some other impacts, and those lost productivity costs, for example, or the costs of unpaid care, could be measured in cost terms. They could be measured in well-being terms. It could be that that loss of productivity, the unemployment that Andrew and Richard were talking about, translates into actually an almost permanent stream of lower well-being. So somewhere in the evaluation, we need to pick up on those other impacts. I've got them listed here as costs. They could easily be on the well-being side, on the outcome side of the evaluation. The point is they mustn't be missed. Okay, I'm not going to say detail about the utilisation patterns and how we measure them. There's a whole range of things there, and I think the slides will be available to you afterwards. But we in our studies usually have to rely on individual recall, the patient, the service user, the carer, to tell us the information, because our administrative systems simply aren't comprehensive enough and good enough to measure those things. And on the cost side, there are many different options. Again, I'm not going to go through the details of those. Obviously, you can start with the budgets for delivering those services. You can go to the literature on what are the opportunity costs for things which don't have a ready market price. And the bottom bullet, if you're working in the health and social care in slightly broader area, I am biased when I put the word price this because it's my research centre at another university. But this annual volume is unique, actually, in the world for having this routine annual set of data about the unit costs you would use in these kinds of economic evaluations, mainly in the health and social care area. So on the cost side, the messages are breadth of measurement, careful measurement, and we want to try and convert things into cost. That's relatively straightforward. On the outcome side, What we're interested in is a range of measures. I'm going to just quickly talk about 3 in a moment. Ideally, those measures would have a number of characteristics. They're directly related to the service aims, of course. We're trying to achieve effectiveness in this respect or in that respect. We'd want the people who are going to use those services to play a part in helping us to decide how to measure some of those outcomes. Need to capture impacts of everyone affected, and so on through the list. And what you were hearing this morning is that well-being is trying to satisfy, if you like, all of those criteria. Well-being, in my view, probably alongside other measures, at least for the moment, but well-being is trying to capture those desiderata, if you like. What is it we're measuring then? We're measuring the area under the curve. And I always apologise for this being the absolute pinnacle of my achievement in computer art. But if somebody, without intervention, I've just marked that their well-being deteriorates over time and at some point they die, we might have an intervention which we think is better for them, and that might have 2 impacts. One, it actually improves their well-being during the course of that expected lifespan. Secondly, it might actually add more years to life. And so those are the 2 lines, and that quadrilateral area there, that is the outcome. We're trying to measure that area under the curve. The area between those 2 lines is what we're ideally trying to get to when we measure outcome for an economic evaluation. So how do we measure it? There are 4 basic approaches. One is we measure it in terms of, and I've called them effects, I can't think of a better word for them, in terms of natural measures. So in health services research, these are the sorts of things you would see: measures of symptoms, functioning, disability, health-related quality of life, behaviour, and so on. Those are the things that we would expect to see in a health service evaluation, because those are what the health service is trying to do. They're trying to improve scores, measures, levels of state, if you like, along some or all of those different dimensions. We might go to slightly we've used the term fluffy today, but slightly fluffier measures. How much choice do people have? How much control do they have? What's the impact on their family? What's the impact on the wider society? Now, those are well-used, whole range of measures in the health service space. They have, most of the measures that are used have really good psychometric properties, lots and lots of experience with using them. But then there's also been this development of the more generic measures, and the QALY was mentioned earlier this morning by Richard. The Quality Adjusted Life Year is the measure that health service researchers have used to try to capture the generic impact across different diagnoses or domains. So it's a measure you can use in psychology, in psychiatry, in oncology, in paediatrics, in cardiology, etc. There's also another one which WHO push, which is a Disability Adjusted Life Year. They're both trying to be capturing this generic, more generic health-related impact. So that then takes us to this question, because decision makers strategically, and actually most decision makers, are facing difficult choices where those natural measures of effectiveness will be a limitation. Because what is a natural measure for a mental health intervention will not be a very sensible natural measure for a community program of some kind. Okay, so we need the generic measures, and the 3 that we've been talking about already, I'm just going to say a little bit more about each of them, are money, utility, in the QALY sense, and well-being. So on money, and Richard talked about this well this morning, the difficulty we have is, yes, there are different ways in which we could look at what these money measures are. It could be expenditure saved, which is absolutely relevant, but it's a very, very narrow measure of any sort of monetary benefit. We could ask people to state their preferences, and maybe to state their willingness to pay, but as Richard said this morning, and I fully agree, there are many areas of public policy where that's going to be an incredibly difficult thing to get sensible responses from. We could look at revealed preference and how people behave, and does that show us their implicit monetary value, and that's been done to some extent in transport area, but there aren't many areas where you can do that. You can look at compensation settlements, but they're next to useless from this point of view. You can look at market value in some cases, and then there's a bit of a growth of interest in this SROI, social return on investment approach. And if anybody wants to ask me a question about that, I'm happy to answer. It'll take me 2 hours to answer it probably. I blow hot and cold, mainly cold, about SROI. So money is one way of going about getting a generic measure across these different programs. The second one, and the one that's used in health, let me put all this up now, the second one that's been commonly used in health is the QALY, the Quality Adjusted Life Year, and Richard described it this morning. It goes from 0 to 1. It's trying to be this generic measure. And this is now a very widely accepted approach, and I think there's a lot of learning in relation to well-being, in relation to that history of the acceptance of the QALY. It is not there to replace the disease-specific measures. It is there to complement and to allow that more strategic decision-making discussion to go ahead in a helpful way. And then the third area, of course, is well-being. And I'm not going to say much more than what's on this slide here because other people are much better placed to do that, and you've heard quite a lot already, and Paul will illustrate that. But there are some challenges, and these are the sorts of challenges, many of these were coming up this morning in discussions about how we might interpret some of the evidence that is around. So let me move then to study design. I said I've got just one slide on this, and again, this is something that could be talked about for ages and ages. There are many different study designs. I'm just going to put up, just listed 5 of them there. And as I say, later on, I'll illustrate 2 of them, the randomized trial and the modelling, the simulation modelling approach. I think the key thing to put at the bottom there, each study design has its advantages and disadvantages. They cost different amounts. They take different time durations. There is, to my mind, there is no single design which is going to be universally the best thing to do. I always say that if my GP says to me, here's a new medication, I want you to take this medication, it'll deal with whatever problem I've got, I want to be absolutely certain that that has been tested properly in a randomised controlled design. I'm not putting chemicals in my body which haven't been properly tested. But I don't need my local council to do a randomised controlled trial to decide whether to empty my bins every week or every fortnight. Okay, so there's different levels of evidence we need for different types of decision, and I think we've talked a lot about the randomised trial, which I do loads of them, I'm really passionate about them, but we don't need them all the time. That's my point. Okay, now on to the making trade-offs, which is that 5th building block in economic evaluation. The core question now is, if the answer to that first policy question, or practice question, does this intervention work? That is it effective by reference to either natural measures or QALYs or well-being or some monetary measure? Is it effective in that way? If it's a suggestion that it's effective, doesn't necessarily have to be, but it looks like it's worth getting into the next bit of the evaluation. The economic question is just a simple 4-word question. Is it worth it? And I'll show you in a moment, the answer to that 4-word question is 2 words. And as I always say, they're not rude. Okay, they don't have to be rude. Okay, so is it worth it is the question. What do we mean by that? We have to define, obviously, what we mean by work. That's the outcome thing. And worth, I'll show you that in a moment. And the decision maker will often face difficult trade-offs for the reason I showed you earlier, or said about earlier, that costs might suggest this is attractive, outcomes on the other hand suggest this is not quite so attractive. So how do we trade off those different directions of suggestion for the way we should go? So the question then is it worth it? Is something, the usual example is when something is more effective but also more costly. Okay, so slides have moved from that old-fashioned dimensionality, which I like, to this new-fashioned dimensionality, and all my circles are in the wrong place. But that's meant to highlight, is it worth it? Now that made it more, remember it more now because it's in the wrong place. Okay, now this is the way in which health economists at least would particularly look at the is it worth it question. Okay, they use this cost effectiveness plane, and it's a simple diagram to illustrate what the results of an evaluation might be, and then help us to perhaps understand what follows from that evaluation. So if our evaluation is up in that top left-hand quadrant in the northwest, what's that saying? It's saying that the costs for the new intervention, new service, cost 2, are higher than the costs for the old one. Okay, so we've got this new service, it's more expensive than what we do at the moment. The effectiveness is saying the effectiveness for the new service is actually less than the effectiveness for the old. It's the negative side over there. So we have a new service which is less effective and more costly. So my economic evaluation question is it worth it? The answer is 2 words, but they're probably rude in this case, okay? Because if I come into your office with this new service, why on earth would you be interested in it? It's going to cost you more money and it will deliver worse outcomes. So that's not cost effective. Down here is clearly cost effective in that economic sense because it's saving money to actually achieve better outcomes. So those 2 parts of the quadrant diagram are really straightforward. If we go down to the bottom left corner, we're in this quandary now. The new service, new intervention is less effective than we have at the moment, but less costly. So the question would be, is that cost effective? And we want to hazard what the 2-word answer might be? Yeah, exactly, okay, top of the class, okay, so it depends. What does it depend on? Let me show you 2 examples, A and B. A suggests that this new service is going to save a large amount of money for a very small worsening in outcome, whereas B is going to save almost nothing and the outcomes are much worse. So I probably think that A is better than B, although that's not necessarily my decision to make. But A is not still necessarily cost effective because we don't know. It's up to decision makers to weigh up those costs and those benefits, and I'll come back to how they do that in a moment, or might do that in a moment. Of course, A might be pretty attractive because all that money you save, you could reinvest in additional services for the people who are getting slightly worse outcomes. So they get some complementary services which actually raise their well-being above the level it was before. So the it depends comes in. And over here, the it depends comes in as well. Y looks like it's going to be much, much more effective than what we do at the moment for a very small additional cost. Looks pretty attractive to me. Z, on the other hand, is going to cost a lot of extra money to save a small, achieve a small gain in outcome. So again, we're in this it depends territory. Now, how then do decision makers make those decisions? And there are a number of options. I'm just going to put them up on the slide here now. One is we could show them that picture or show them the results and let them get on with making a decision, which is what they've been doing for centuries. Okay, that's what people do in that job. It's a difficult position. Health economists have developed something called a cost effectiveness acceptability curve, which is really just a diagrammatic way of showing them how something could be more cost effective if they, the decision maker, are willing to pay more for each unit of well-being or other outcome measure. The second will be to ask decision makers to be quite explicit about willingness to pay. But as Richard was arguing this morning, for example, that's incredibly difficult in many territories. And the third is to set a threshold. And NICE do this, and Richard mentioned this as well, that NICE have this threshold of between 20 and 30,000 per QALY. Now, the NICE process, I just need to take 30 seconds of your life to explain the NICE process because I'm a real fan of it. What it does, they identify the questions, they gather all the evidence they can on those questions on effectiveness and cost effectiveness. They then build new models, economic models of what the cost effectiveness might be. They have wide consultation with service users, with families, with people who provide, and they publish a guideline. And the guideline comes out in very clear format. That is the penultimate stage of the NICE process, okay, the penultimate stage. The ultimate stage is the day after the guideline is published. And that's when they get slagged off on the front page of the Daily Mail. And the Daily Mail will say, NHS body condemns breast cancer women to early death, or similar such. I've got loads of examples on my computer. And that is about this it depends question, that somebody, some journalist, some newspaper proprietor, thinks that they have a different view from the NICE view about whether it's cost effective to do something. So it's not an easy or a non-controversial issue. What's then this threshold? Well, oh good, it did stay in the right place with the new design. This threshold, you can illustrate the cost-effectiveness threshold with a straight line through that plane. And points above the line would then be not cost-effective. Points below the line would be cost-effective. You could measure that threshold. Richard suggested one in terms of cost in relation to units of well-being, that 0 to 10 scale. NICE look at it in terms of QALYs gained. You can use that threshold to then provide a guide to what might be considered to be cost-effective. It's not a rigid guide. It's there to guide, to influence and support debate. If I put another point on my little picture, X, and draw a new threshold, the amount that is that the decision maker is willing to pay is different. Now that point X, which was cost effective under the old threshold, now the new threshold, which is more exacting, is tougher, it is no longer cost effective. So that threshold is really going to be pivotal in deciding how we sort of concretize the it depends answer. Okay, final slide. I've tried very carefully, actually, throughout the presentation not to use particular labels for the economic evaluation, because there are many, many different labels. Cost-effectiveness analysis is used both in a narrow sense and a broad sense. I've just put some on there. There were 2 others that got mentioned this morning. Value for money was one, and cost outcome evaluation was another. There are lots of different labels. It doesn't really matter hugely what label we use, as long as we are very clear about what we mean by it. So arguably the label is not so important, as long as it's absolutely clear what is being measured and how it is being measured. And then finally, I'm just going to put up my email address and thank you. I haven't put my conflicts of interest statement up as I was supposed to do, but I have none that reflect this, that have affected this presentation. So thank you.
Back again shortly. We're going to Paul's going to work us through some examples and have a go at yourself as well.
Thank you very much, Nancy. Thank you very much, Martin. I also think that we're going to hand out homework. I'm sorry about that. Nobody's going to check it. This is more so that sort of in the later part of my section, you can sort of check for yourself whether or not you sort of have absorbed and got on top of most of the major arguments that we've gone through so far. But I will first talk you through some examples, and you will find that the last example I talk about is the prelude to this particular exercise, which I will then encourage you first to do individually and later on to talk about within your small groups. That could be either the person next to you or small groups of 4 if 2 can look back and 2 can look ahead. So let me give you some examples that come from across the What Works Wellbeing Center on the cost effectiveness of various interventions. Right. I'm first going to talk about the Housing First evaluation. This has to do with homeless people. I'm going to talk about the Crosscutting Team, which is us, me and Richard at the center, and Jan would also be coming in. And we try to draw together strands of lots of different areas across the UK policy spectrum to get at this wider whole-of-life view of how interventions affect people themselves, their communities, the taxpayer, to get at a life satisfaction profile, as Martin has illustrated, that hence gets you to the area under the curve. And then finally, I'm going to talk about problem solving for stewards. Now, the general Excel format that we're going to go towards has lines in it that is based on generic outcomes, if you like, and the 2 outcomes that we're going to care about most in my presentation, which are total costs and total benefits in terms of life satisfaction year points. And so the way that the Excel sheets that I'm going to talk you through are going to work is that they will have several outcomes, and some of these outcomes would not be the final outcomes, but they could be the direct focus of an intervention, for instance. So if you focus on homelessness and you try to make people less homeless, well, the first outcome you look at is, am I succeeding in making them no longer homeless? And so these are going to be various outcomes, and they're going to have different labels. And then the question is, well, how has that outcome changed in period 1, period 2, period 3, period 5, period 6? And if you're going to combine them all together, preferably discounted, although the examples I'm going to show are going to be undiscounted, you're going to have totals over the whole period of the intervention. And then what you would like is to have an overall life satisfaction effect per person. And that is going to get you a combined discounted total, which is going to be A. A is going to be our measure of total benefits. And just similarly, you're going to have costs. And I've here shown you 3 different types of costs. The one is the internal cost, which is the cost to the organization who does the intervention. So if, let's say, the police organization has an intervention, then it's all the costs directly to the police organization, more manpower, different equipment, whatever. But there's also external costs per person, and they could be the costs on other parts of the service. Could be the prison service, could be the health service, could be some other part of the public sector or non-public sector system. And so these are external costs per person, and of course, because we want to have a societal lens, we want to get a total cost per person, and total cost per person is going to be our second number, B. And all that cost effectiveness is just the pounds per unit of life satisfaction that we have, is hence going to be B divided by A. So B divided by A is going to be the magic number that we're interested in order to compare different interventions across widely different types of the public sector or society at large. So that's where we're going. So how about Housing First? Well, Housing First has been interested in an intervention on homeless people, and they have two different types of systems in mind. The green system is the status quo system. The status quo system whereby each person who is sort of involved from the civil service into homelessness has a caseload of 20 to 40 people. That is the traditional support. So they're trying to look after many, and they're interested in things like night shelter, hostel, transitional housing, and hoping that that leads to independent housing. So this is the support system we have at the moment for homelessness in the UK. And they were interested in the question, well, what happens if I have a Housing First intervention whereby effectively what you do is you pick up the homeless people, you sort of run an analysis on them in terms of how severe the problems are, and essentially from a mental health and conduct disorder type of lens as to the severity of systems, and then you might directly put them into permanent housing. And so the idea is that you will often have an apartment for them somewhere at the outskirts of the city, and you put them in there and you surround them with a lot of additional health support, and hence you go to a much higher, as it were, amount of effort per homeless that you put in. So the caseload is going to be much fewer persons per individual who's on this type of program. And the question is whether this much more intensive set of treatment for the homeless is going to be cost effective. Now, targeting in the UK for this Housing First program has been for high problem cases, so people who are severely mentally ill, and they took their analyses of how effective such a program would be from Canada, where they actually looked at how to intervene here and what the alternative outcomes would be. And so they were not aware of trials in the UK which compare homeless who were just left homeless with homeless who were intervened in terms of a Housing First intervention, and hence they had to go to another country to get an idea of how effective in terms of life satisfaction improvements and other improvements would this intervention be, and then they also worked out what would this cost in the UK setting. So, in order to get these life satisfaction improvements, the community wellbeing team had to look at a similar experiment in Canada, particularly Toronto, and the Stegiopoulos et al. Study was used to get estimated improvements for year 1 and 2. So this is in Toronto. They intervened and they followed up for 6 months and hence 4 times in the life of this particular project, and hence have at least a sense of how life satisfaction changed year 1 and year 2 into the intervention. Now, in order to get at costs, the community wellbeing team had 2 sources for costs. Right? One was, as it were, a low-cost estimate, and one was a high-cost estimate. So there were 9 pilots of this in the UK that were at least costed, and there was an analysis by Brereton and Peace's analysis, and they looked at experience costs, but not all of them. So, for instance, the costs that they left out are the costs of many of the service providers who are around homeless people. And so for a high-cost estimate, they also took the estimates which came from Blood et al. 2016, who costed what this kind of intervention would actually cost in Liverpool, and hence with real data on how high that apartments would cost in Liverpool, how high the health service costs would be, etc., etc. And there's a huge difference between those 2 cost estimates, and I'll tell you later on how crucial that turns out to be. Now, what is the Canadian experiment that they base their key numbers on? We're looking at 2,150 homeless individuals across Canada, and new cases were starting in 2009 to 2011. These people were followed 2 years, so the whole study is from 2009 to 2013. Now, each 6 months, these people were extensively interviewed, and nurses were brought in, all kinds of medical measurements were taken, but they also went to a lot of effort to measure the other costs you might think that are associated with homelessness. In particular, hospitalization degrees and criminal endeavors and drug use. Right? Those are the three big ones from a public sector perspective. And some of the findings surprised me when I actually read up on this study. I had not anticipated it, but it seems that those who got the intensive treatment, those who got permanent housing, were not more likely to stop substance abuse. They also had an equal or even higher number of arrests, sort of borderline significant in a statistical sense. That surprised me. Right? They were also no better integrated in the community in Toronto, but they were less likely to have emergency department visits at the hospital. So just from that, as a headline, you can already start to wonder whether or not this would have been a very cost-effective study, and that is one of the real takeaways from that study. So if you then think about, okay, what is the cost effectiveness going to look at in the UK? I'm hence looking at a bit of a hybrid beast. I'm looking at a cost effectiveness number for the UK based on the effectiveness in Canada, hence presuming that what the effectiveness in Canada was is going to be the same as the effectiveness that it would have here in the UK. But the costs are not taken from Canada. The costs are taken from the cost what it would be in the UK. And there's a huge difference because essentially housing prices are very high here. And so that already creates a large difference in costs. So we are looking at a hypothetical of doing what the Canadians did, but under UK prices. And of course, only parts of the whole picture are looked at in this cost effectiveness. They did not look at long-term effects because the study was limited to 2 years. They did not look at employment effects or effects, for instance, on the family around a homeless person. They were not able to reach them and hence see whether or not there were benefits there, which there could well have been. So at baseline, undiscounted, the community wellbeing team then estimates, this is this big number, B over A, the cost per unit of life satisfaction on the lower end to be £4,232. Now, as Richard already showed, if you would apply the same type of threshold as is used in the QALY analyses, then £2,500 per unit of life satisfaction would seem to be the initial focal point, so that would already be outside the range of what is cost effective. But if you use the higher estimate, which hence comes from this analysis of how much it would cost in Liverpool, you'd actually get at £27,762 per unit of life satisfaction. And there is such a high uncertainty in all elements on both the benefit side and the cost side, meaning that the team has come to the conclusion that at conventional levels of thresholds, the probability, if you allow for the uncertainty that's going to be cost effective, is close to 20% or lower. So this effectively would not meet the grade in most analyses. So if we then fill in our Excel sheet and we change some of the labels, 3 of the outcomes include days that people are stably housed, and over a 2-year period, that change is 298 for the people who were intervened versus not intervened, so it had a high direct effect on, indeed, whether or not people were stably housed. Yes, for 300 days over a 700-day period, they then were. If you look at another outcome, this is the EQ5D. This is a measure of mental health. I won't go too much into what it means, but it's one of the key measures that is used in health for cost allocation. That improved slightly. Then mental illness severity, that also improved slightly, which means it got worse. And if you then look at the overall life satisfaction effect per person, it was measured on a 0 to 6 scale in the original Toronto study, which meant that over 2 years, if you add them together, was a 0.4 increase. If you then rescale that to a 0 to 10 scale, which is what we're used to here in the UK and internationally as the most used format, you get at 2/3. And that then gives you at the low estimate the £4,232 per unit of life satisfaction, and at the high estimate, the £28,000 per unit of life satisfaction estimate. So that's our case number 1. And we're going to have a large question and answer session later on. So if you have questions about this, please save them up, and we'll talk about it then. Now, then the cross-cutting team example. So this is what we did at the center, is that we looked at a hypothetical intervention as well in the UK, but one that is very close to what has actually happened in the last 6 to 7 years. And so that allowed us to compare what was predicted to happen the last 5 to 6 years with what actually happened. So we looked at what a hypothetical treatment of 25% of depressed individuals in 2010 and roughly speaking, in 2010, 16% of the UK population was depressed. What would it have meant for them if we intervened with them in terms of their mental health, if we put towards them what is known as this increased access to psychiatric treatment, which has been rolled out in England and the rest of the UK ever since 2008. So we're effectively investigating the cost effectiveness of the IAP treatment, and which is currently being expanded to 1.5 million citizens. And we're looking here at the hypothetical effect of what that treatment would have had as an effect if it had all been implemented in 2010. So in 1 year, suppose at reasonable cost estimates, we'd have been able to help 4% of the UK population in 2010. How would that have fanned out the next 5 years? Now, what is our essential approach to tackling a question which is as large as this? Because the mental health of individuals interacts with many other systems, both for them as families and for them in the public sector as a whole. There is direct cost effects in terms of having treatment, but there's usually also cost savings in terms of health services that they then no longer use. There is effects on their employment, there is effect on their partners, there is effect on welfare usage, and those all have to be evaluated. Now, some effects can be lifted from the trials. So this is one of the most studied mental health interventions known to mankind. It's been trialed for about 20 to 30 years in one guise or another, or at least aspects of this kind of program. But trials are typically short, and they typically only focus on patients. And so many of the effects are not known from trials. So some effects can be lifted from the trials, but only known for specific years. And loosely speaking, we know the effects on mental health and some of the other areas in the year that it happens, the year afterwards. And for one particular trial, which is actually a UK trial, we know what happened in year 4. Now, that is the longest follow-up that we have on the effect of this kind of intervention. What happened 4 years afterwards, which is pretty long for medical interventions. And that means that most of the effects actually have to be filled in. We have to get them from somewhere else. Now, the cost of the trial itself is sort of known in the sense that we know how many people it takes to push through this program, to set up the websites, to set up the additional GP services, etc. But that doesn't tell you about all the costs. As Martin said, the costs come in many guises. And because we here have a public sector lens, we're interested in the cost on taxation. We're thinking there'll be some recouping of taxation because people are more likely to work, so they're more likely to be taxpayers. They're less likely to be in welfare, so we're likely to recoup some money for the public sector by having less people on welfare. But there's also going to be effects on partners and other relations, and we take those from the literature. So many effects are hence model-derived, if you like, but they're all based on estimates in the wider international literature on these aspects. In a sense, we've made nothing up ourselves. Now, to sort of pre-shadow the end result, what we have is that if you look at the life satisfaction before an intervention, and hence the zero life satisfaction is a very, very small group of people. This is, I think, less than 1% or something, not even that. Then you see that for the group who are most miserable before the intervention, these are, of course, the people most likely to be intervened in. So there you see a relatively large effect, a cumulative effect over the ensuing 5 years of 0.15. Now, if you think 0.15 is not that huge, you should, of course, bear in mind that only 1 in 4 of the depressed is actually treated. And you should mind that this is, of course, a yearly thing, and so that would be multiplied by 4 already if you'd think of treating everybody who would be depressed. Now, this effect goes up for the people who initially were a 1, a 2, and a 3, and they go up because these are the people for whom the effectiveness of the intervention itself was probably highest. This was most likely led them to go out of depression. So for the people who were, as it were, ultra miserable, the intervention didn't lift them out of depression itself for large parts of the intervention period. But the people who were just close to being depressed or not depressed, which would be the 3 and the 4s in our sample, for them the effect would have been highest, and hence that's also what we see in terms of this total life satisfaction effect. And the effect of these interventions are much lower at higher levels of life satisfaction because these people were much less likely to be depressed in the first place. And as somebody already observed, if you're a 9 or a 10, there's not much further to go. By the way, it does happen. It's possible to be a 9 and depressed, but such people are very rare. Now, what's our overview then? And I'm not going to talk too much about it, but I just want to give you a flavor of all the kinds of things that we want to draw in this study. So if there is an intervention, there's a primary effect of the mental health of the patients. That mental health of these patients has a direct spillover effect on their partner. So the majority of them have a partner, and we know that partners are affected by roughly 0.1, 0.2 to the degree that a patient is affected. So you get an extra benefit of 15% on whatever the effect is on the directly treated via their husband or wife if they have one. And then we also know that mental health is intimately tied to important areas of individual behavior. So the behavior we looked at, for which there's a lot of literature evidence, are employment. We know that the mentally healthy are more likely to get a job, and we're more likely to keep a job. So both those effects are things we looked at. We know there's an effect on physical health. The mentally healthy look after themselves better, their immune system works better, and hence their physical health also improve. And that also comes with cost savings. And we know partnerships are affected. We know that people who are mentally healthier are more likely to become partnered and stay partnered. So all these things are things for which there's a lot of stuff known in the literature, and we were able to code up these effects of this particular intervention. Then that works through markets, right? Because the people you are directly treated are more likely to become employed or to stay employed, that of course changes market outcomes. It effectively shifts the supply curve of people. Now, that means that there is a counter reaction. In principle, with more people working, wage levels are going to go down. And with wage levels going down, other people are going to be unemployed, and they're going to have more problems. And similarly, as what Andrew Clark already talked about, if some people are going to make more money, then other people are going to feel less well about the money that they have, because they are then more jealous. And so because we want to be serious about how much life satisfaction we're actually buying on the whole population, we also want to take account of these what we call macroeconomic or macro effects of this whole intervention. And this is a fairly standard economic macro model that we have in mind for the labor market, and these reference points are now becoming very normal in happiness research. And then when you count all that together, you then have final outcomes, and the final outcomes are in terms of the public purse. So you have costs of this intervention, the direct costs. You have advantages. You get a bit more taxation, a few less transfers, and you also have cost savings for the health service. And they turn out to be rather large because people with less mental health problems are less likely to show up at the hospital or use other aspects of the health system, and that turns out to be really worth an awful lot. And we calculate everything in terms of life satisfaction. For some of the trials, we actually measure life satisfaction, and so we can see the direct effect of these cognitive behavioral therapies, because that's effectively what the intervention is, on all the individuals. But we also know what the effect is of employment, physical health, income, and partnerships on life satisfaction, and hence can also trace that out, both for the individual and for all others affected. So what are we here evaluating? As in the previous example, we're evaluating a hypothetical, which is a hypothetical IAPT intervention on 25% of the depressed, anxious population in 2010. No other interventions, otherwise business as usual. We have a population on which we show this outcome. This is the Understanding Society data set. I don't know if people are familiar with the old BHBS, but this is the main longitudinal panel that there is in the UK. It's been up and running for close to 30 years now, I think. And how do we measure depression? We measure depression via the GHQ-12, which is the General Health Questionnaire 12, which is effectively a measure of how much mental stress, mental discomfort one is going under. The higher this measure, the more mental discomfort one is under. And if you are a 4 or higher, that's the criterion we use as to whether or not we count you as depressed. And in 2010, that was 16% of the population. Now, to give you some example of the causal relations we hence plug in, if you look at this GHQ-12 score, those who are intervened, they would go on average from a 7 to something like a 3.5, so 7 problems on average. Those who were intervened in GHQ-12 means 12 possible problems. If you're above a 4, you hence have a 1 in 4 chance of being treated. This shows you what the effect is on those who were treated. You see a large reduction. Effectively, you reduce by almost 3 out of 12 problems. That is a big effect. And I was surprised. This was somewhat new to me 12 months ago, that cognitive behavioral therapy is so effective in getting people to think better of themselves and their lives. What is equally surprising is that that effect remains. So in this trial I talked to you about, which followed up people 4 years later, it's a Cobait trial. Yes, after 4 years, they still were almost exactly as beneficial as they were in the first year that they were treated. And hence the treatment effect stayed almost constant throughout the 4 years of that trial, which was a real surprise to me that it didn't, as it were, taper off, but apparently it doesn't. And so you see that this benefit of this intervention in 2010 really keeps going until the end of our data sample period. And this is the primary effect that, of which the effects we're trying to model. Now, if you then look at this of the sort of the relapse scenario, so this is a secondary scenario in which we presume that the relapse rates are higher because we're running simulations, we can run alternatives as well. This is our baseline scenario. This is our less optimistic scenario, in which effectively half of the effect is gone after 5 years. Now, what does this mean for reduced rates of depression? If you look at the treated population, the effect on depression is highest in the first year, but becomes less high in the second year. That's when the gap between these becomes less high. And why? Some people get depressed again, or they have such high problem scores that they don't actually go below this threshold of 4. Right? And hence that's why you do see a tapering in the depression rate, even though you don't see a tapering in the GHQ-12 rate. Now, let me give you an example of where our coefficients come from. As I said, we didn't want to make up anything ourselves. So, for instance, how do we know what the effect is of mental health on partnership stability? Well, we went to the literature, and so we tried to look for the most authoritative studies which fit the UK population best, which you would sort of reasonably say, yes, that would also fit what would happen here. And this was a study by Reichman et al. In the Review of Economics of the Household. And what they could exploit was that some women fall into post-natal depression and some women do not. Now, according to their arguments, and most of the medics that I've talked to sort of seem to agree, that indeed is something almost unanticipated. It affects some women, it does not. We don't quite know why, but it leaves us with the ability to follow, as it were, the effect of this almost random shock in whether or not somebody is depressed, i.e. postnatal depression, yes, no, on whether or not their partnership survives this postnatal depression. And what did they find? Well, the impact of a major depression on relationship status. Well, if you're previously married, it makes you 7% less likely to stay married. Right? If you're not cohabitating, previous cohabitating, that increases 11 percentage points. And so these are quite high percentages, right? And they're high costs of mental health, and they're hence strong improvements if mental health does improve. And so we basically just lift this coefficient. If you stay out of depression, well, you're 7% less likely to lose your marriage. And you're more likely to become cohabiting in the years following the intervention if your mental health hence improved. So that is, as it were, it's an example of how we lift causal relationships from the literature. Right? So if we then show you, well, what does this intervention mean for other things? The net monthly income benefit starts to be around 50 per member of the total population. So for an affected person, it's much less. Physical health improves, but that improvement doesn't last all that long. The percentage single sort of goes up and then down in this scenario. And the hours worked per week, the improvement also tapers off a little bit, but see that the majority of the effect in the first year is 1.8 hours per week, drops to 1.2 hours per week, and all these effects are still in the quadrant in which we expected it. Now we can then decompose these secondary effects, so we can talk about the changes in life satisfaction per person of the population and decompose it into, well, where do these effects come from? And one of the largest effects is on physical health. There's a bit of effect that comes from employment, partnership, and income. You cannot quite well see these colors, so I don't want to talk about them too much. If we then look at where the benefits to the public purse come from, there's a bit of benefits from additional taxes collected over time. There's a bit of benefits from the within household spillovers. This is because the partner feels better, they're more likely to work as well. But the vast majority of the public sector savings come from reduced costs to the health service. So this is the health cost saved is by far the most important effect. And if I then tell you that this intervention costs something like £1,000, £800, then you will see that already within 2 years this program pays back just mainly via the health cost savings. And so it's a highly cost-effective aspect. So we can then go to cost per WellBeing, and we can go to cost per WellBeing for the whole of the population. And this, in order to get a positive cost per WellBeing rather than a negative one, we're assuming that these public health costs are suddenly not there, because otherwise it becomes a exercise. And so if we for a moment forget about the benefits to the health system, then the cost per well-being would be £300 per unit. And this is from everybody. And then if you can think, well, can we find a group for whom the cost effectiveness is higher? Yes, the unemployed, because they're more likely to get a job, and hence for them, and they're also slightly younger, so you get a longer payback, and they're more likely to use welfare benefits. So for the unemployed, the cost per well-being would only be £40. Is there then a group for whom the effects would be less effective? Yes, those would be the retired, because they haven't got a job to lose. Right? And for them, hence, the cost per well-being would be 410. And similarly, you can look at the cost for those below 30, more likely to use welfare. And if we then look at the less positive scenario, the relapse scenario, you'd still look at a highly cost-effective intervention. Now then, in terms of our famous Excel sheet, if you do this for this cross-cutting example, you're going to get a much bigger one. I don't expect you to be able to read all these, but effectively we're now going to have to equivalize the life satisfaction effect of all kinds of changes. So life satisfaction effect of income changes, employment changes, reference health, reference income, all kinds of stuff. And if we then zoom into some of these, you see that there's the year 2010, 2011, 2012, life satisfaction change on, for instance, the partner mental health effect, and you see all these various elements. Now, this thing has been filled in. It's a bit of a dog's breakfast, as you might imagine. And so I'll just zoom in on the last thing that's important. That last column shows you the total undiscounted effect over these 5 years. The overall life satisfaction effect per person, and this is now per person treated, is 0.5. And the cost effectiveness of that intervention is £330 per unit. If I then go to the example 3, how much time have I got for the examples? How are we doing for time? Are we doing good? 15 minutes, okay. So this is adapted from Jody Ayres and John Malouf. So this is problem-solving training to help workers increase positive effect. And we're effectively going to look at flight stewards in Australia. I'm not allowed to say Qantas, so I won't say Qantas. But these are flight stewards in Australia, and they were given a problem-solving module to do in about 8 to 10 weeks. And problem solving is one of the main areas, main subcomponents of cognitive behavioral therapy, and psychologists have told me that it's in fact one of the most effective parts of cognitive behavioral therapy. So I'm going to talk you through that. This is in Australia. I've lived there for 16 years, and the flight attendants will almost certainly have lived in that corner because that's where nearly everybody lives in Australia. So basic background, what are we talking about? Well, airline stewards in Australia have very scripted and regulated jobs. So for most of us, I think that'd be very boring. They're told when to fly, where to fly through, what they're supposed to do, you know, bring out the snacks then, and if people react to you, this is exactly how you should react back. So it's being very much paid to be a scripted monkey, right? And for some, this is a very stressful job, right? It doesn't feel like you have much autonomy at all. And researchers wanted to know, well, what if you give these people training in how to overcome problems, so problem-solving skills? And they convinced an Australian airline to just let them do it. So what is the training? Well, they had 111 people volunteer for this training, and these people filled in surveys before and after the training, and 56 got the training and 55 did not. So note that we here have a group who has an intervention, and we have a control group who also wanted the intervention, so they're comparable, but they didn't get the intervention. And so these two are exactly the same from an ex-ante point of view because the 56 were randomly chosen. So we're looking at a randomized controlled trial. All those who wanted the training, only 56 got it, 55, too bad, you did not. What did the training consist of? Well, the training consisted of mainly time with the chief researcher. So it consisted of a 30-minute chat about life and life's problem over the phone with the first author of this particular study. That's what you get if you're a PhD student. I know it's not me. There's homework. So you got a 30-minute chat, and then you got homework whereby problems had to be written down. You had to see yourself as somebody who could have a particular problem, experience a particular problem, and you were then told to write down when you experienced the problem, how you experienced it, what you thought the cause was, what you could do about the cause, and hence to objectify yourself in many ways. Right? And there'd be regular checkups throughout the 10 weeks or so that the training took, to see whether the participants got the basic idea of this, were keeping up with their diaries, what their experiences were, and to help them overcome some of the conceptual problems as to how they could deal with some things. Now, what were the outcomes in the 4 weeks of the outcomes? So the ones with training improved 7.64 in a particular score, which they termed positive effect. So this is how strong your mood is. Then there's also something they called life satisfaction. That was not on a 0 to 10 score, but on a 5 to 35 score, because it was made up of 7 life satisfaction type questions, each on a 1 to 5 scale. And hence they went up by 2.65 relative to 0.82. And there was a job intervention, so there was also a job satisfaction improvement. And the cost of this intervention was, drumroll, £148 per participant. Right? Now, they then standardized this, right? And when they standardize this, they basically, so standardizing in terms of 0 to 10 life satisfaction, standardized in terms of what this would cost somewhere else. So the study found it would cost £148. But if you think that the effect halves every 8 or 9 months, if you think there's some tapering off and the effect totally stops after a year, then the benefit would be, or the cost would be £202 per unit of life satisfaction. Right? So they had to make an assumption on what happened in the months following this particular intervention, because they actually themselves only measured people once, namely right after the intervention, so after 1 month. If you, on the other hand, go to an extreme alternative assumption, so their assumption is effectively that most of the effect lasts for 1 year and then disappears. If you alternatively assume the effect truly only lasts 1 month and then immediately disappears, then you'd be paying £2,424 per unit of life satisfaction. Now, notes on the cost here. The costs are for the intervention, so not for the study, but that wouldn't add so much. And the participants, note that these now include some people who got the training but were then lost, i.e. they quit, right? So because some of those didn't actually fill in the questionnaire, but they're still presumed to have had the same benefit of it. So you're making assumptions on, well, what happened to the people who ran away from the study before I had a chance to measure what the effect of them was? You're going to have to make an assumption, and the assumption they made is that it would have been the same cost effectiveness for them. Furthermore, these costs are not based on what it costs in Australia. It's again what it would cost in the UK to put the same amount of time into these flight stewards. So we're again looking at a hybrid hypothetical. The effect would be like it was in Australia. The cost would be like it was in the UK. And you can play around with, well, what if the actual cost would be double the one they state, and what if the effect would only be 1 month? Could we then get something that is not cost effective? And of course you can. So it tells you where to look for the key assumptions. So in this case, if we fill out this famous Excel sheet, then the intended outcome was problem solving. That went up by a certain amount. There's a direct cost. Other outcomes were job satisfaction and life satisfaction effects on externals. That is 0. They did not look at partners. They did not make assumptions about whether the partners would benefit. And if you then look at the direct effects, which would also the overall effects of life satisfaction per person, you then get a benefit of 0.72. And hence that gets you the cost effectiveness, the pounds per unit of life satisfaction, were £205.56. Note this does not include production and payments made foregone, and so there are many other forms of cost they could have put in, but they were not put in. Okay, that concludes the official part of this. Now I'm going to involve you. So please look at the sheet that you've been given, and please spend the first 8 minutes or so doing the free exercises. And after your 8 minutes, which I will let you know, you'll be asked, okay, now please discuss this with your neighbors and come up with a common answer. Best of luck. Ding, 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 ding. Where's a glass where you need one? Okay, well done, everybody. Thanks for getting so much into the spirit of this thing. I don't know if anybody got to the last question, but I'm trying to crowdsource my own research efforts here, so I'm hoping you got something good there. So I only have suggested answers. As I said, we're not actually going to check. But the first one, hence, is on the externals, is on reference group effects, right? So suppose you have research showing the mood effect on the average individual has a 20% effect on the mood of a partner, and that 80% of the stewards have a partner. Well, that effectively gets you a 16% multiplier. Now, the 16% multiplier hence has an effect of a further 0.111. That's 15% of 0.72. And so then you get the total life satisfaction effect per person of 0.8352. And that hence changes the cost effectiveness from £200 to £177, or basically 16% better. I don't know who got that, but if you did, you're like-minded to, to me. On the second one hence has reference groups effects in it. This is this notion that what puts other people up puts other people down. And in this hypothetical, this killed off 3/4 of the effect. Now, if you're filling this thing in, it has 3/4 of the effect on every aspect. So one of the other outcomes hence would be the job satisfaction reference effects, and the job satisfaction reference effects would hence be 3/4 of the initial effect on individuals, and 3/4 is 3/4 of 0.56, which is hence minus 0.42. And similarly, there's the life satisfaction reference effects, because I made as it were, the question easy, it was 3/4 of all effects. And so there you got a minus 0.626, and hence that gets you at pounds per WellBe of £708 per WellBe that you're still then left. Effectively an increase by a factor of 4 on top of the previous one. So the 708 is basically 4 times that number, because we still have the initial effect on the partners in there. Right. Now, on free, I actually didn't do this myself because I was hoping that I'd get research funding for free by having you do it. Who came up with something interesting? Has anybody had time to look at the internet what the retention effect might have been? What would be a reasonable effect? Because I know that improvements in job satisfaction improve job retention, but so did Andrew Clark, who immediately said, why don't we look at where do people keep their jobs? Well, exactly. Has anybody found something in the few minutes they had available for this? Any whiz kid scourged the internet? Nope, I'm not surprised. We didn't give you that much time. But if you like to do this at home and work for me for free, please send me the answers. Thank you very much. We're now going to go on back to Martin.